All right, so our next two presenters are Dr. Kohlmeier and Dr. Warren. Oh my goodness, I can't believe it. I almost forgot your name. Dr. Warren. This is a great session because Michelle has been hard at work gathering questions online for the last couple of months that are common questions that are being asked of doctors. And then we'll also have the opportunity for people in here to be able to ask questions. But we wanted to just say thank you to Dr. Kohlmeier. She is the chairman of our medical advisory team, so we're excited to have her participate today. And our newest member is Dr. Warren, so we're excited to have him participate. So I think what we're going to do is go ahead and start with Michelle, and then we'll ask anybody in the room if they have any questions, other than they can't answer any personal medical advice for you, but any questions at all, and if they can answer it, they will absolutely do that. So Michelle?
Okay. The first one that came in online is, why does your VPATH affect thyroid hormone, and does it only affect thyroid hormone for those of us who've had our thyroid removed?
Great question. Good to be here. I'm excited to be in Texas.
Did not bring my hat. I don't have a hat. She's a cowgirl.
Well, we'll wait for tonight for everybody else to bring their hat. I think it's so important for everybody to know that when you stop taking your multiple calcium supplements, you're going to absorb everything so much better. And so we really have to think about thyroid. I've had so many patients that all of a sudden they're feeling anxious and tachycardic and, hot, and it's because their thyroid level hasn't been dropped, their dose hasn't been dropped to accommodate that increased absorption. Now, not everybody, because I know you probably try to take your calcium 4 hours away from your thyroid, so you're going to maximize absorption anyway. But you really want to get your TSH checked every 6 weeks, at least in the beginning, as you're coming off all the calcium. Otherwise, it shouldn't affect your thyroid that I'm aware of.
Yes, and that's why I always have them at that 4 to 6 week period go ahead and get their TSH checked as well.
Do you recommend patients with hypopara go on a low-salt diet? I've never heard that one.
I'm sorry, the door shut right when.
A low-salt diet. I've never heard that one before.
Go ahead.
Well, no one likes a low-salt diet. I love salt. Some people have to be on a low-salt diet if they have high blood pressure, but usually people with high blood pressure go on medications, and maybe the low salt helps or it doesn't. But the reason that's really important in hypopara is that without parathyroid hormone, over 60% of patients spill calcium. Now, thankfully, they don't all make kidney stones, but over 30% do. And so when you have a low-salt diet, you're lowering the amount of sodium your kidney has to excrete. And when it excretes sodium, it just pulls out calcium with it. It's just a passive mechanism. And so kidney stone patients really can't stop making stones if they have a high salt diet, even if we put them on a thiazide or uracil K and lower their calcium to, not a hypopara patient, but 800 milligrams a day, because we see a lot of patients that don't have hypoparathyroidism that spill calcium, and over time they get osteoporosis. So I think that the only reason you wouldn't need to think about a low salt diet if you have hypoparathyroidism is if you're one of those rare lucky patients that does not have a high urine calcium. And I would say less than 200 milligrams, which is pretty low.
And fortunately, with PTH replacement, that's often normalizes. So their hypercalciuria, the urinary calcium goes back to normal, so it's not much of an issue anymore.
So you can increase your salt again.
Is there anybody in the room before I ask another online one? I'll give him time to get up, but I'll go ahead and ask another one. Someone is asking, if someone is prescribed steroids for a medical condition while on PTH replacement, does calcium get lower the same way it does in conventional therapy?
I've not seen that to be the case, but you have.
Great question. In the trials that there was a limited amount of steroids that were allowed for you to stay in the trial. I mean, we would never hold steroids if you needed them for allergies major inflammation. But to enroll into the trial, for that very reason, steroids were limited. I haven't seen anybody's calcium drop in a dangerous way if they've needed steroids. I think they're in a much better, safer place on Yorvipath than on conventional treatment, where you absolutely would worry about calcium absorption on steroids. As an endocrinologist, we really don't like steroids. Nobody likes them, even though it's a miracle treatment, right? Anti-inflammatory. But I would worry more about that. So if you're on Yorvipath and you need steroids, think about it. Make sure you have calcium with you. Try to taper off the steroids as quickly as you can, just like we do otherwise.
I have a question.
Can you introduce yourself and where you're from?
My name is Rob Temple from Omaha, Nebraska. We didn't bring our hats, though. Sorry, but we are Western Nebraska Cowboys. So we have a question for you. I'm a runner. I'm interested in your Strides for Strong Bones Awareness Walk. Nonprofit. That sounds fantastic. I'd love to hear some about that. But my question is, there was a discussion earlier. When you're active, you're exercising, does your calcium level, I'm not on a trial, by the way, does your calcium level deplete? Is there a way to boost it? I just ran a half last weekend, and at mile 10, I boosted with 750 milligrams. And I finished stronger than I've ever finished. And I think there was a correlation, but after hearing what was earlier said, it was almost like, no, your calcium doesn't change from one week to the next. I think that's completely against what my body experiences. So, as an active runner, what is your opinion on, should we be boosting like that? Is that a good practice? I've only had it, I'm post-surgical, I've only had it for 4 years at this point. So I'm still trying to get that understood, in running, but just curious to know what your thoughts are. Thanks.
Well, I have a lot of people that don't have the exercise tolerance, and I think that they find their calcium requirement is higher. Of course, your muscles are using the calcium to contract, and so that's not unusual to see that.
It's a great point. Michelle and Patty will remember the first few years that I came to the meeting, that was the topic I chose, exercise and hypopara. How do you exercise? And there wasn't a lot of literature. I looked and looked, and of course I was learning from you and my patients. And most of the literature I could find was the veterinarian literature. It was in racehorses. And essentially the racehorses have to get IV calcium, and they have normal parathyroid status if they trailer them a long time. So absolutely your calcium drops, and if you have parathyroid function, it goes up. We just never know or measure it when you're an athlete. And when you're, really an extreme athlete, and, what you just did is extreme to me. Not only is it good for your skeleton because you're turning on those bone-forming cells, but you need more calcium. And, you're in a much better place on parathyroid hormone replacement, if you can be, than on conventional treatment. But even on Yorvipath, I have to remind some of my patients, which is a great thing, you still have hypopara. Can you believe it? That people kind of start forgetting? It's unbelievable. But I'm like, if you're going to start exercising again because you feel better and all the other safety things, I want you to have a medical alert. I want you to have one of those calcium cards. And I think you did exactly the right thing.
I mean, how many patients have you had that have never got back to their level of exercise or activity they were before their surgery? And then you put them on PTH replacement, and they got their life back. And that's just, I mean, it's so critical. I think that's one of the things that I don't think the doctors actually ask their patients enough about. You look great on paper, see you next time. No, you got to ask and delve a little bit more.
Hi, my name is Sarah Leitz. I'm from Michigan, post-surgical for almost 20 years. I have two questions. The first one is, so for postmenopausal women that are not hypopara, they usually advise taking calcium. So once we go on the PTH and we're not taking calcium anymore, can you speak to that?
But you're getting it in your diet, correct?
Correct.
Right. So I don't like calcium supplements, and I'm talking to a room of people that live with multiple calcium supplements. So if I'm talking to a patient that doesn't have hypoparathyroidism and they're menopausal and concerned about losing bone density, I'm going to still ask them to get it in their diet if they can tolerate calcium and if it's low cal if they're trying to lose weight. So I think that goes for the same. So if you're hypopara and you're on parathyroid hormone replacement, I still want you to either get it in your diet. You don't need to take extra when you're menopausal, but you still want to get, 1,000, 1,200 milligrams. That's almost nothing for hypoparathyroidism. That's all you need menopausally.
But it still takes several servings of dairy products. So, and if you're vegan, that's a little harder to do. So you have to look at your calcium intake in your diet, and that's the best way, obviously. But if you need to supplement, that's okay too.
Thank you. My second question has to do with symptoms. So on the symptom list for the neurology, it talks about the Parkinsonisms. And so I started having head tremors and voice tremors probably about 5 years ago. And so the diagnosis is essential tremors, and nobody's really linking it to the hypopara. But I remember, Dr. Kohlmeier, you talking about us having higher neurosensitivities, and I had gone on Cymbalta and had tremors with that. And so my question is, in general, is there more to be done in the diagnosis of that if you have hypopara? And whether or not that's the case or not, if it is if it's the neurosensitivity from hypopara, is there something else that needs to be done with management or diagnosis with that?
I don't know of much literature about that. I think they're probably separate things, but I think hypocalcemia can make certainly the tremors a bit worse. But I don't really know much literature about that.
That's one of the questions I keep asking all of our investigators, that exact question. So absolutely important to have everything else looked at just in case it's not related. And that's, Michelle and Patty have been big advocates of that. It's like, we can't put everything in the hypopara box, even though it seems to all fit and be appropriate, but you got to make sure that something else isn't missed. And it sounds like you're doing that. But often it takes going to another specialist, and you may have already been to a specialist for something else, but I think that's important. I know that the calcifications in the basal ganglion and other studies that Bart Clark and others are doing are going to help us understand this, because I tried to really figure out why would people get Parkinsonian symptoms, and it isn't any more clear to me at this point either.
All right, thank you.
Online, we have one that asks, why isn't calcium glycinate ever listed to use as a calcium supplement, only citrate or carbonate?
I think that, I don't know exactly, but I know certainly calcium carbonate is easily found, and so is the others. So I'm not sure. Probably just availability and cost. But
I think a good take-home message is the best calcium for you to take when you have to take a lot is the one you tolerate the best, but not to trust the least expensive brand. And I would never have known. How do we know if calcium's really absorbed? In the non-hypopara world, you don't know because people can't really tell, but So if I had a patient that was on probably 10 grams of calcium and traveled a lot, had to take a whole suitcase of calcium with him everywhere he went. And, he got some bargain calcium one time, and it was not what it said it was. So I'm not saying that this type of calcium's like that, but I would say that when you're looking at calcium until you're on Yorvipath, when you won't need to anymore, hopefully, Try not to buy the least expensive brand and try to stick to the ones, not that this one wouldn't work and if you tolerated it, but you get more calcium, like Dr. Warren suggested with calcium carbonate, as you guys know. But calcium citrate tends to be better tolerated, even though you only get, 23% elemental. And then some people like liquid calcium. So you guys are the calcium experts. I wouldn't cross any type off the list, but I'd be skeptical.
Okay. And is there, oops, I just switched my own page. How can we better explain our condition when we have to go to the ER to the doctors there?
How can you explain, say that again, please?
How can we better explain our condition when we're in the ER to the doctors there?
Wow. Well, the ER docs are not very well versed, and as Bob was saying earlier, that is fortunately they've got he's been able to work some protocols out. I think you have to go in and well versed yourself and explain to them what you need. So that's about what you need to do. I'm hypocalcemic. I need IV calcium. And this is how much you need to give me, or they can look it up, but this is what I need.
And bring your advocate, wear your medical alert bracelet, and have your card, and it's bad. Don't be tough when you're in there. Make it even worse than it is. Say, I'm going to have a seizure if you don't get me some care. I don't want to exaggerate, but you know how terrible it is, and I understand that, they have gunshot wounds and people that are having heart attacks, and, so I'm not minimizing anything else, but I think being your own advocate and having somebody else there is going to get you some action that you need.
Okay, thank you. We'll go to the mic over there, and then we'll continue online.
My name is Ashley Wilkes. I received a diagnosis at the age of 17. I've had it for about 19 years now. So I wanted to piggyback on that. Is there anything going on in the background with physicians trying to advocate for their patients with insurance? I have been denied. I laid in a hospital bed for about 2 weeks just waiting for a reauthorization, and they just had to sign the paperwork. I was in critical condition. Fast forward, I got a new insurance company who also denied it. With all the years of trial and error, I advocated. My doctor has been my doctor since the age of 13, and you're saying to advocate and fight for it. We know what's going on, but the insurance companies continue to deny us. Thankfully, I had the Ascendus program because I was denied and we did the appeal. I have Yorvipath for free now, and this is the first time in all these years that I don't have any symptoms, and I've been not in the hospital for 6 months, but I was averaging about 3 to 4 months. I would be inpatient. So is there anything going on in the background with the doctors trying to build a stronger relationship with insurance companies?
Wow, that's a lot. So this is our reality every day in practice of medicine is pre-authorization. Almost every medication requires a pre-authorization that's not a generic. So it takes a lot on the staff, and we work hard. We all know what they need, and I mean I have phone calls once or twice a week as peer-to-peer, supposedly peer-to-peer, but peer to somebody, and trying to say why that person needs what they need. And so usually it works, but they put walls in front of you so that you won't climb them. So you've got to, your provider needs to continue to work with that. And it's tough, but it can be done. And it's not the physicians that, it's really just it's the insurance companies that don't want to pay for it, and they put walls in front of you. That's just it's a big barrier.
Your story's incredible, and the question's so important. The companies have helped us. We learn that everything's rejected first time around now. It might be AI. It might not even be a person on the other end. I want to be optimistic that AI is going to help in some way. And so, maybe that's something that someone could look into, as if there's certain words and certain, specifications that maybe the computer that's listening is not going to just kick it right back. I think that from an endocrine standpoint, Dr. Warren's pointing out that we're pretty overwhelmed with all of our medicines being denied, but that doesn't mean we need to have search for support, like you're saying, and work together. It's a great point.
Thank you.
I just want to make a comment on that. We appreciate the work you do. I know it is a lot of work, but what we can do as patients is encourage our doctors not to give up after that first denial. Dr. Kohlmeier just hinted to that. And with my own denial earlier this year, we learned the facts at the HPA that less than 1% of insurance denials are ever, people don't try again. They stop, they get that denial and they quit. And I don't know if it's because doctors don't have the time to go that next step or what it is, but we as patients need to really encourage and push and offer to help in whatever way we can so that we don't give up after that first denial.
And we are actually working with the insurance companies in North Carolina. We're working with them with Blue Cross as a pilot program that they'll let us, they won't require pre-authorizations for some of our diagnostic stuff. So hopefully we can parlay that into medications as well. In North Carolina, one of the legislators is introducing a bill that if your denials are less than, or they finally approve 80% of what you request, then you get a gold card. You don't have to do it again. So, and there's one other thing he's trying to push is if they deny it, then they become a provider, and so they're liable for your care. So that might change things a little bit. So we're working legislatively, but it takes a while, and it's costly to medical practices too. For 6 providers, we have 1 full-time employee. That's all she does. So that's costing our practice of 1 full-time employee with benefits just to do that. So it's costly everywhere.
I have my own iStat, so I'm able to check my calcium for 3 to 6 times a day. But even before this, when I would be in the hospital, my ionized could be low or even critical low, and I could have a normal whole blood. And it happens now almost all, like 95% of the time. My whole blood will be normal, ionized is low. So I was going to ask if y'all have seen that. And then also, when I crashed in June, my first symptom was lethargic, and thank God I have a 24-hour person with me. But when that happened in the hospital, I lost moderate hearing in my right side and mild from that crash. I fell to an ionized of 0.83. And thankful the ear doctor realized that when I told her it happened at the crash, she confirmed it. But after I started looking, it is a rare thing that can happen. But have y'all ever seen a patient do that from a calcium crash, lose hearing?
And can you introduce yourself too, please?
Oh, I'm Sissy Paul from Louisiana.
I've not seen loss of hearing from acute hypocalcemia. I've not seen. And is the hearing issue still there?
Oh, yes, sir. I'm getting
Okay.
my hearing aids
Gotcha.
Tuesday. I'm supposed to be ordering them. It damages the nerves of the
Yeah.
cochlear, is what they explained.
Has anyone else had that happen or heard of that in anybody here?
Yeah.
Thank you for sharing that with us. And what about the ionized? Do you want to comment on that hard question?
Gosh, that's a tough one. It's, ionized, it's easier for us to get the total calcium, and I don't usually monitor the ionized. They usually correlate, but sometimes they may not. So certainly, I guess in your situation, they didn't correlate.
Usually in the hospital or in the ICU, ionized is used more, and in the outpatient, we don't usually, but we try to correct with albumin. But we're going to have to get back to you on that because that's a great question we don't have an answer to.
Okay, online I have one that says, why does potassium get low after becoming post-surgical hypopara? I am not taking diuretics.
Good question. So I would say that you've just had surgery and there may be other electrolyte issues going on. It should not directly be related to parathyroid that I'm aware of.
I agree. I think that's probably changes in your diet around the surgery, and maybe also could it be low magnesium, because you have to have magnesium for the potassium to control the potassium level as well. So it could be from low magnesium level.
And the only other thing that could add to that is if you're post-op and you had any vomiting, that can lower your potassium too.
Question over here.
Go ahead.
Hey, my name is BK or Blake. I'm from Gulfport, Mississippi, and I have a couple questions. One is you had mentioned getting the TSH checked every 6 weeks when you're on Yorvipath. My question is for those of us who have our TSH suppressed with Synthroid following thyroid cancer. I have been trying to lower mine for several months now, and it has not budged one bit. It's still, less than 0.01. Is there any advice on that? And we can do that first.
And do you have your free T4? I know we're not supposed to give exact advice, but it's important to have a free T4 in addition to a TSH, especially when your TSH is suppressed, because your pituitary hasn't had to do much lately because you're taking a little extra thyroid than you need. And sometimes it takes time for it to come back. And so we have to be careful we don't actually lower thyroid too quickly. And that's usually when TSH isn't detectable at all. So if it's 0.1 or 0.2, that's different. But if it's less than 0.1 or less than 0.5 on the lab slip, that means it's undetectable. And it takes a while, but I think if you're lowering your thyroid dose and watching free T4 as well, and your calcium supplements are stable, because if that's changing, then that just adds another variable. Either way, if we're checking it every 6 weeks, it definitely should change.
Okay.
So I think it's really the pituitary, the cells that make the TSH. They're basically quiescent, or they're sleeping. They become very small. It takes a while for them to wake up. Often, we see it may take months before the TSH, starts to come up. So, as she said, you have to be a little patient and not adjust too quickly, because it may not be really telling you what's going on with it. The TSH may not be indicative of your level that you need for a while.
And one important point with that is, let's say you drop from 150 micrograms over time to 88 micrograms. I mean, that's a big drop. And usually people need about 1.6 microgram per kilogram of their weight. That's kind of a guess that we do, and we usually start a little lower so we don't overtreat people that don't have thyroid cancer. If you dropped your dose and your pituitary still showed an undetectable TSH, but your free T4 was in the bottom of the normal range, like 0.7, 0.6, you could be very hypothyroid and miss it. Because just like in patients with hypoparathyroidism, let's say you have, I know I'm switching subjects, let's say you have partial hypopara, or you're not sure whether you really have chronic hypopara yet, and your calcium drops to 7.7, of course we're suspicious, but your PTH is 30, and so your provider says your parathyroid's normal. That's not true. Your parathyroid should be 130, right? Because your calcium's so low. So that's why, it's really important that we don't miss hypopara in patients that don't have a low PTH. So same with TSH. If your free T4 is really low, because your pituitary is working great, not related to your parathyroid, it should be high. And so that's why as you lower your thyroid dose, you want to measure both.
Okay, and now my brain fog's hitting me really hard on that second question. But sidebar, I was a pituitary patient long before I had thyroid cancer, so doctors don't really want to touch me. The other thing I think was in regards to HRT and calcium, and whether it's for postmenopausal or trans folks. Is there much being done to study that? Because, menopause wasn't really studied until the 80s. So there's a lot of us going around who doctors are like, sending them to this doctor, sending them to this doctor. My OBGYN will not touch my hormones. And my endocrinologist is going, I don't know what to do with you either. So, and healthcare in Mississippi is not great.
So your question is, does hormone replacement affect calcium in patients with hypoparathyroidism, and/or what are hormone replacement recommendations in menopause? Because that's a whole great other question we could spend a couple hours on.
Right, because my doctors are not giving me a single
But which of
answer.
those two? The first one related
first
to your
one.
calcium, or
Really
just in
to my-
general?
in with the hypopara in general, the calcium, the PTH, because my doctors don't know a single thing.
So that question sort of came up earlier today, and we were looking at articles, and so she found a nice article. So there is some interaction with estrogen therapy, and if you take away the estrogen therapy in hypopara, your calcium level requirement may go up and your calcium may go down. So there is some interactions there.
And how many of you who still have normal menses and are not on Yorvipath yet on conventional therapy find that their calcium fluctuates during their menstrual cycle? Did you guys notice that? Good, a couple of you, yeah. So my patients haven't really told me that, but we, learned that earlier. So I think we know that estrogen replacement and contraceptives affect albumin levels and binding globulins, and we know that as endocrinologists, we know that. We know we have to hold estrogen for some cortisol testing to look for Cushing's, so we're always kind of thinking about that. I think because there's so many variables that change your calcium with hypopara, I don't think estrogen's going to be at the top of the list, so I think you should use estrogen as you need to safely for your symptoms or for whatever else is important. Estrogen's a great hormone, though it has some risks. And I think the second part of your question was in menopause. And, I'm a big fan of estrogen. Most endocrinologists are. And we know that the WHI now is so old, 2002, and it was inappropriate that so many women, in my opinion, were taken off of estrogen. On the other hand, we know that it does increase blood clot if it's oral, not as much topical. We know that with progesterone, it increases breast cancer in some women. And we know that we don't start older women, 10 years past menopause on estrogen now, usually because of a potential increase in stroke risk. But despite all those risks, I still think the benefits outweigh them. So it really depends on finding somebody that can go through all that with you and talk about estrogen if it's appropriate in menopause.
And I would say that if you're otherwise needing estrogen, it shouldn't really affect whether you take it, whether you have hypopara or not, as long as you're monitoring your levels and not suddenly stopping it, suddenly stopping the estrogen.
Hi, my name is Sandy, and post-surgical hypopara. And I'm from Florida. So my question is, when you have various testing done, so I recently had a bone density done, and I thought about this when I had it done the last time also, is you've got great bone density, and I'm thinking, and I've been seeing the updates about the thick bones, and it was interesting because I had some surgery done, and they were telling me that I have severe osteoporosis based on the surgical part. So when you're having this normal testing done, like I said, they're telling me I'm just great, but I don't think I'm just great, but that's okay. So,
We think you're great.
how do you address these things, like when you have calcification in the brain because you've had a scan? So how do you address this? What do you do? How do you take the information that you get?
That's a lot of questions.
I'm sorry, I don't.
That's okay.
I
I'm
don't
going to
ask
summarize your questions.
often, I guess.
Let's summarize your questions. Okay, the first one's really important. It's one of the hot topics in our world. Okay, not here, right? I mean, we want to talk about it too. But here, I think the hot topic is safety, advocacy, getting off of conventional therapy and onto parathyroid hormone if it's appropriate. There's going to be very few patients that I think don't need a trial of Yorvipath. And I know that wasn't your question, but that's important. And because, you turn on bone when you go on Yorvipath. So let's say, I'm not saying this is you, but let's say I have a postmenopausal woman who inherited osteoporosis from her mother. You always blame your mom, though you love her. And maybe she needed steroids when she was younger, whatever the reason, but she already has osteoporosis. And now she has post-surgical hypoparathyroidism. So that is one of our big hot questions in endocrine in this world. So I have an answer to that, and I know that we have some great speakers on Sunday that are going to talk about that. But to be more specific to what you've watched already, in general, patients with hypoparathyroidism have their bone turnover turned off, and so they get hypermineralized bone. We don't know if it's better bone, but we know it sure looks dense. And when you go on Yorvipath, thankfully, we're not supposed to use the word normalization, but that's what I think it's doing. It's turning bone turnover on again. It's waking up the skeleton. It's releasing calcium when you need it for healing and for your blood and everything else. But in the beginning, when bone turnover goes up, and we know exactly in the pathway trials with Yorvipath how many weeks it took, the beautiful thing, in our opinion, is that it stabilizes and it comes down into the normal range, and then it holds steady. So even though you do lose a little bit of bone density in the trials, patients did, in the beginning, they didn't continue to, and you know how long the studies are. And the last thing I'll say, which was just such great news for us, was the people that had the lowest bone density, which were very rare. I mean, a handful of people had low bone density, and very few had osteoporosis. They lost the least amount of bone, and it was the people with the highest bone density, +2, way above normal. They're the ones that in the beginning lost the most, but it's still stabilized. So it's complicated, and these are the questions we're getting all the time, and we'll get them a lot more this weekend, but it's a great point.
Because I saw that study that was in Sweden where they did hypopara patients, and they found on bone densities that they had osteoporosis and a increased fracture ability of the vertebrae, but the hips and femurs had a very low comparative to the general populace, which was just an interesting, that's kind of what tweaked when I read that study.
No, really good point. I'll just say something real quick. So there's two big registries. There's Elia Khan's in Canada, and then there's an Italian registry that's looked at this, and I don't know specifically the one in Sweden. You'll have to share that with me. But we do know that probably up to 30% of patients, mostly postmenopausal women, that have hypopara may have osteoporosis too. So we're learning about this, and we are skeptical that dense bone is better. We want it to be normalized with parathyroid hormone replacement.
Yeah, I don't know how to reconcile the bone density is really good, but the surgeon said otherwise. I don't know if there's a huge increased risk of fractures with the hypopara. It looks like there's not. But it's thicker bone, but it's not normal bone as we saw earlier.
And just real quick before we go to the other microphone, regarding that question, Dr. Rubin will be here this weekend, and she has done a lot of skeletal research with her SHINE program, and she can maybe answer that a little more. And we'll go to you.
Yes, my name is Shannon. I'm from here. I will tell everybody that unless we're on the ranch or the rodeo, we don't really do the hats much. But yours looks fantastic.
I've been told that.
It looks fantastic. And the question about menopause sparked me with this. And for whatever it's worth, I don't know where you are. Most doctors don't know anything about menopause anyway, whether you're hypopara or not. So I don't know, throw that into the whole mix. That's been my thing. I'm not hypopara. I support somebody who is. And it did get me thinking about, that question got me thinking about birth control. Are there any particular concerns that somebody should think about when you're hypopara and you're using oral birth control? Are there any recommendations? I was just wondering if anybody could talk to that a little bit.
I don't think there's any concern about using it. One concern, again, with paper we saw earlier today we were discussing is someone who had been on birth control had it stopped, or a calcium level previously was hypopara, dropped quite a bit. So I think you have to be a little careful about stopping and starting, although obviously with birth control pills there's a week of not getting it. So.
I agree. I think there's so many other variables to decide what's best for you that I wouldn't think that hypopara would come into play. Progesterone by itself isn't good for bone, so the progesterone only birth control pills I'm always kind of against. Now, preventing pregnancy and safety is always going to be more important than some of these other endocrine things I worry about. And even way back in the day, Depo-Provera for contraceptive was never really there weren't strict guidelines to say we need to do a bone density. We're going to be upset about this because we didn't want to minimize the importance of Depo-Provera use. But long-term progesterone use really isn't good for the skeleton. So I'd rather estrogen be involved if it's a contraceptive as well.
Okay, online I have one that asks, why do hypopara patients still need regular vitamin D on top of the active vitamin D?
I love that question.
I know you love that question. That's why I'm smiling.
I know.
This is her big issue right here. She loves
this is so important. So just as long as I understood the question, so this is on conventional therapy. Why is taking vitamin D important when you can't turn it into active D? And I'm going to add a second part to the question, because just in case they meant when you're on parathyroid hormone, why is taking regular old active D, not active D, taking regular old D3 over the counter important? So to answer the first part, I've had providers ask me that exact question, say, why would I put my hypopara patient on 2,000 units of D3 when they can't turn it into active D, and I'm giving them prescription active D? Why should they have to do that? And it's a good point, because it doesn't have as much effect when you can't turn it into active D. But we've known for decades now that 25-hydroxy vitamin D, which is what your body can, with or without parathyroid hormone function, can turn the D3 you take over the counter or the D you make in your skin from UVB light, even though I'd rather you take it over the counter and not get lots of wrinkles and spots in your skin, and you put on any sunblock and it blocks vitamin D. So, being out in the sun is a good thing, but don't depend on it for vitamin D. We've known that you have vitamin D receptors not only in the skeleton but in your muscle, and so 25D can go to those vitamin D receptors without being turned into active D and can help. It reduces falls, it makes people stronger, and it's one of the reasons that vitamin D, which you guys know is a hormone, not a vitamin, got so much credit. Maybe 10 years ago, it got too much credit, but it deserves a lot of credit. So it's just too much of a good thing isn't good, but that's why I think everybody needs to have a 25-hydroxy vitamin D level of at least 20. That's what the Institute of Medicine says. In endocrine, we want people to be 30 to 40. 20 is not really good enough. So to answer the second part of the question, in the trials, patients had to have a vitamin D level of 20 in one of the trials, and in another, the hypopara trials, of 30, even to get into the trial. And that's because once you go off your active D, that 25D is what you're using with your now new parathyroid hormone replacement to turn it into active D. So as Dr. Warren said, it's one of my really important take-home messages, because if you forget to take your D3 because you feel so great and you're forgetting you have hypopara, which I love, but 3 months goes by and your vitamin D level, because it's a fat-soluble vitamin, takes a while for it to disappear if you stop taking it. If it drops to 5, your Yorvipath's not going to work as well. It doesn't have anything to make active D, and without active D, you can't absorb your calcium in your diet. So that's a really important point.
That was a really awesome point to make. I don't think a lot of us think about the fact that maybe if our Yorvipath is becoming less effective, that is something we need to pay attention to. Thank you for that. Okay, I think we're going to get ready to wrap up. I have one more question, and I'm going to make it a two-part question because you just made me think of something. But it says, can you explain a little bit more about the relationship of our magnesium, potassium, and calcium together, like how they depend on one another and why it's important to get all of them checked? And the second part to that is going to be, once we are on a PTH replacement, do we need to continue to worry about the other electrolytes, the potassium and the magnesium?
So the magnesium is important because it's often low in hypoparas. So it's important to have that. And the potassium, as I mentioned earlier, you've got to have normal magnesium level to maintain a healthy potassium level. And I think that once you're on PTH replacement, it doesn't seem to be as important to monitor that.
Well said. I don't have anything to add to that.
Okay. We're going to end with that question because just a whole bunch more came in. I'm sure we could keep you guys busy for the next hour, but I'll save some of these questions for the rest of the weekend. Thank you very much.
All right. So
Thank
thank
you,
you, Dr.
guys.
Kohlmeier, Dr. Warren.